Okay, so what I'm going to go through is spectrum of immune-related toxicity, so-called immune-related AE, irAE. We're going to look at the time of onset of immune-related adverse event, difference by time of agent, and then try to answer the certain questions. Is it detrimental to our patients to give steroids for management of immune-related adverse event? Is it safe to give immunotherapy for patients with autoimmune disorders, HIV, hepatitis, and organ transplant? Is it safe to re-challenge our patients after they develop the immune-related adverse event? And then we go through general principles of immune-related adverse event management. So immunotherapy works for everybody, silly. So this is their example of current timelines of immunotherapy approval for all cancers. And so you can see that the graph is expanding very, very rapidly. As in 2014, we only had 2 drugs approved, and between 2017 and 2018, we now have 7 drugs approved. So immunotherapy is here to stay. And as a practicing physicians, we have to be very aware of how to manage immune-related adverse events, because if you don't manage it correctly, you can actually detrimentally affect your patients. So what happens with immunotherapy? Immunotherapy causes T-cell activation. So because T-cells are activated, it balances our yin and yang, our balance between self and non-self balance that tips towards autoimmunity, and that results in immune-related adverse events. So there are certain characteristics for the immune-related adverse events. They are reversible if treated promptly. If left untreated, they can progress to a more severe state. If treated early, the severity and duration decreases. Anything can happen. Any organ can be affected. Typical onset of immune-related adverse events is about 6 to 12 weeks after initiation of chemotherapy. So not extremely early, but within the first 3 months. However, they can occur within days of the first dose, after several months of therapy, and the most important, even after discontinuation of therapy. You could stop immunotherapy for one or another reason, and then the patient can develop immune-related adverse event a month or 2 after discontinuation of immunotherapy. This is an example of what we would expect for the PD-1 or PD-L1 inhibitors, using nivolumab as an example. So you can see that majority of the adverse events happened within the first 3 months. And you can see that the number of patients with adverse events depends on different organ affected. So skin is a more common complication, but something like renal or hepatic is less common complications with PD-1, PD-L1 inhibitors. What we also know, even though we do not have any CTLA inhibitors approved right now for lung cancer, but based on the preliminary data, it is very possible that they will gain acceptance in lung cancer. We also know that for those drugs, there is a slight difference in incidence and severity, as well as type of adverse events. We see much more hypophysitis with CTLA-4 antibody and different patterns of liver toxicity. This is an example looking at the difference between types of immune-related adverse events seen in CTLA-4 versus PD-1 and PD-L1. And you can see clearly from that graph that CTLA-4 inhibitors have a higher incidence of immune-related adverse events. And between PD-1 and PD-L1, the difference is not as apparent. Also, you can see that grade 3 and 4 adverse events are also more common in CTLA-4 inhibition. However, despite the fact that immune checkpoint inhibitors can cause adverse events, majority of those adverse events are early grade. You can see that the incidence of grade 3 toxicities are not as high. Also, we have, initially when we were developing PD-1 and PD-L1 inhibitors, we started asking the question, could those drugs have different adverse event profile? And initially we thought that maybe PD-L1 inhibitors would be safer. But now we have a data, it's a meta-analysis, but still a lot of patients, 23 studies, that doesn't seem to show any difference in incidence of immune-related adverse events between PD-1 and PD-L1 inhibitors. What we also know, and that was seen in melanoma data, that people who developed immune-related adverse events seems to have a better outcome, at least in melanoma. We now have some early evidence in retrospective analysis of non-small cell lung cancer patients showing the difference in progression-free survival and a difference in overall survival between the patients who actually developed immune-related adverse events versus not. And this is, I think, logically can be easily explained that you somehow were able to stimulate the immune system more effectively. So how does one start immunotherapy? So the one thing we have to be aware is that the chances of your patient developing adverse event depends on a predisposition. So you have to somehow get a sense of what is the likelihood of your patient developing immune-related adverse events. And one thing we know that patients with autoimmune condition have a more likelihood of developing immune-related adverse events. So the typical autoimmune conditions such as rheumatoid arthritis, SLE, scleroderma is very well known to us, but you have to also ask about less common autoimmune conditions such as psoriasis, diabetes, sarcoidosis, pancreatitis. So is it safe? Like if I have a patient who I'm seeing in clinic who has, let's say rheumatoid arthritis, which is well controlled, is it safe to prescribe immunotherapy in those patients? And the only thing we have is the retrospective data in melanoma, where they looked at 119 patients treated with PD-L1 inhibitors, and 52 patients had pre-existing autoimmune disorder, and it's about a third, maybe slightly over than a third patient, had a flare of autoimmune disorder requiring immunosuppression. The chances of a patient flaring depended on how their autoimmune disorder was controlled. So if the patient had a clinically active disease when starting immunotherapy, the chances of flare was 60%. But if the patient autoimmune disease was not active, not requiring any treatment, then the incidence of relapsing or recurring autoimmune disease was only 20%. So it is safe, but with caveat that you have to be aware or you have to question the patient about the control of their pre-existing autoimmune disorder. Another population that we commonly see is patients with HIV, Hep B, C, and organ transplant. And the idea was that if we give immunotherapy to those patients, can we somehow rev up immune system too much, causing the immune system starting being more effective in attacking those viruses? And the data was presented at ESMO in 2017. We don't really have systematic published data. We have case reports. And this is the first, I would say, a systematic publication that I found, a retrospective review of patients treated in 16 centers in Europe. So there are 42 patients. They had either transplant, HIV, Hep B, C, and they were receiving PD-1, PD-L1 inhibitors for different indications. So there are 5 patients with solid organ transplant, 4 renal, 1 liver. Patient with liver transplant had graft rejection and unfortunately died after first dose of immunotherapy. Patients with kidney transplant did not seem to fare that bad. There were 11 patients with HIV, and the good news is that none of the patients had loss of viral control or immune reconstitution inflammatory syndrome. The AIDS Malignancy Consortium is actually having a clinical trial right now where they give PD-L1 inhibitors to patients with HIV-related malignancies. So we'll have a larger patient sample to confirm the safety of immunotherapy in patients with HIV. There were 14 patients with hepatitis C and 12 patients with hepatitis B, and none had loss of viral control or autoimmune hepatitis. So I think with this data, I'm feeling a little bit more confident and comfortable using immunotherapy with, in patients in HIV, preferably on a clinical trial. But if I don't have a clinical trial, I still have some data saying that maybe it is safe. So how does one manage immune-related adverse event if that happened? So you basically go by grades. I don't expect you to remember what is a grade 3 diarrhea. Thanks to iPhone, there is actually an app where you can plug your numbers and you can come up with the grading of any kind of symptoms. So if you have a grade 1 adverse event, immune-related adverse event, you have to start with a supportive treatment. Antidiarrheal medication, skin cream, hydration, electrolytes. The one thing I want to stress is if your patient is developing immune-related adverse event, it is not a good idea to let them go for 4 weeks and not call the patient. Because you never know when that grade 1 immune-related adverse event is going to go into the grade 2. So you have to increase monitoring of the symptoms, be it a patient advocate or nursing staff or however it works in your system. You have to exclude infections. So our patients are common visitors in the hospital, and C. diff, unfortunately, is very common in our institutions. So make sure that when the patient presents with diarrhea, you are excluding C. diff. And then patient education. So it is very important because sometimes things happen. The nurse could forget to call the patient and check on their diarrhea. It is very important to educate the patient, saying, you know, you have a diarrhea, please call me back in about 3-4 days, tell me how you're doing. So you educate the patients as well. So if you have a grade 2 adverse event, so you basically do everything you've done in grade 1, but then I would consider holding the drug until symptoms resolve to grade 1. If you're holding the drug and nothing is improving in 5 to 7 days, then I would consider low-dose steroids, about 4.5 mg per kg per day. Rechallenge is allowed, and I'll show you the data on rechallenge later in a talk, but rechallenge is allowed for the grade 2 immune-related adverse event if symptoms have resolved. So grade 3, you basically do everything that you've done for grade 1 and 2, so supportive therapy, you hold therapy. For grade 3, I would probably go ahead and start steroids right away, and then also wait for about 2 to 3 days, and if it's not improving in 2 to 3 days of IV steroids, then consider adding something else on top, such as infliximab or mycophenolate. So with those therapies, you wait until the symptoms resolve and then taper the steroids. The key here, taper it slowly. So it should take you about 4 to 6 weeks to taper steroids if the patient develop a grade 3 immune-related adverse events. If you taper it too fast, it's just going to come back. Another thing, since these patients are now going to be on steroids for 4 to 6 weeks, do not forget about PCP prophylaxis, because then you are at a higher risk of PCP if you're prolonging the taper. For the grade 3, rechallenge is controversial, and I would say it needs to be decided on the individual basis. And there is no role for dose reduction for immunotherapy. Immunotherapies are not dose reducible, so you either give it or you're not giving it. So for the grade 4, it's as in grade 1, but permanently discontinue immunotherapy. This is kind of a graphic way of, I'm a visual person, I like to look at pictures. So this is a graphic way of you to remembering what I just told you. So basically, if it's a grade 1, you move up, so supportive care. If it's a grade 2, start supportive care, hold immunotherapy, wait 7 days, start steroids. If it's a grade 3, supportive care, hold immunotherapy, start steroids, wait 72 hours, starts other immunosuppression. And then if it's grade 4, you just put the whole kitchen sink in there. So when we were starting to do immunotherapy in our cancer patients, we were worried that by giving them patients steroids, we might actually make immunotherapy less effective, because steroids are supposed to do opposite of something that's immunotherapy do, meaning suppress the immune system. So we have some data in melanoma showing us that there is actually no detriment in outcomes if the patients who developed immune-related adverse events are treated with steroids. I forgot, either at ESMO or at World Lung, they presented data on prophylactic use of steroids for patients with getting immunotherapy and using steroids for other reasons, and those outcomes were inferior. So I'd say if your patient develops immune-related adverse event, then I would not stay away from using corticosteroids to treat immune-related adverse events. So a couple of key toxicity points, and I still have time. So if the patient develops colitis, and sometimes, rarely with PD-1 inhibitors, but more common with CTLA-4s, patient can develop bowel perforation. So if your patient develops bowel perforation, stop steroids and stop infliximab, because both of them could make surgery healing a little bit more difficult, and you manage them surgically. If you have an autoimmune hepatitis, you could use mycophenolate. Infliximab is relatively contraindicated in autoimmune hepatitis due to its potential for hepatitis toxicity. And again, when you're working up autoimmune hepatitis, don't forget to look for, there is an outbreak of hepatitis A in the US and especially in California. So make sure that you work up other reasons for the patient developing transaminitis. One thing is a laboratory toxicity is elevation of amylase and lipase. If your patient does not have any symptoms suggestive on pancreatitis, it is okay to continue immunotherapy, and there is no indications to give steroids or drug holds. Skin toxicities, usually mild, usually rash and pruritus. Eczema is important. I can't, so many times the patients say, you know what, I have a little bit of a rash here, and then forgot to mention that they have a blistering rash on the back. So when the patient develops skin toxicity, make sure that you examine the patient, make sure that you talk to the patient, because blistering rash could be a sign of impending Stevens-Johnson syndrome, and I would refer them to the dermatology if I see a blistering rash. Topical steroids and antihistamines for mild rash, and then high-dose IV steroids for grade 3 and 4 rash. Endocrinopathy. So there are a couple of tidbits here. So if the way usually thyroid reacts to immunotherapy, initially when you start giving them immunotherapy, you see a very mild subclinical hyperthyroidism. I have not needed to do anything more than just observing the patients and talking to them about side effects, but eventually the hyperthyroidism will develop, and then you just simply manage it with hormone replacement therapy. Adrenal insufficiency has been described, and you treat it with oral hydrocortisone. The one recent learning point for me in managing immune-related endocrinopathy was if the patient actually has a combined adrenal insufficiency and hypothyroidism, you are supposed to replace the adrenal first. Because if you do it other way around, if you give patients thyroxine, that will actually enhance your cortisol clearance and drop the cortisone even further, could potentially precipitating Addisonian crisis. And when you would suspect adrenal insufficiency, if you have a patient coming in and is extremely fatigued, I would certainly consider checking for adrenal insufficiency. Hypophysitis. Rare in lung cancer because we do not give as much CTLA-4 yet. Patients usually present with headache, fatigue, so you would at least think about brain metastasis. So even if you forgot to think about hypophysitis, the brain metastasis will come into your mind, and you will order the MRI. And it's usually seen by enlargement of the hypophysis on the MRI. You diagnose it based on hormonal profile, because 25% of the patients with hypophysitis can still have a normal MRI. And then you basically replace with steroids. I generally refer my patients to endocrinologists. I can't keep it in my brain how many, what hormones and what dose, so I just send them to my endocrinology colleagues. Unfortunately, this is usually irreversible. Hypophysitis most likely will require a long-term hormone therapy. Pneumonitis, not as frequent with PD-1 inhibitors. The one thing I want you to kind of remember, state about pneumonitis, chest x-ray will miss pneumonitis is about 25% of the cases. So if you're thinking pneumonitis, CT scan might be a better option. There are different types of pneumonitis. There is a very nice paper by Scott Gettinger going through different radiographic appearance of pneumonitis I'd like to refer you to. And then neurologic toxicities, rare. People have described neuropathy. Something more serious as Guillain-Barré or myasthenia gravis have been seen. Less common adverse events, basically anything can happen. Patient can have hemolytic anemia, myocarditis have been described in New England Journal paper recently, blepharitis, nephritis. So the next question is, what if your patient develop immune-related adverse event? How safe is it to re-challenge? There was a data published at ASCO looking at 482 patients with single institution study, but basically 38 of those patients restarted immunotherapy. And if you can see that when immunotherapy was restarted, 50% of the patients did just fine. They did not, the immune-related adverse event did not recur. In 50% of the patients, immune-related adverse event recur, and what was surprising to me actually that quarter of them actually had the same adverse event, but quarter of them developed a different adverse event. So if you stop your drug for colitis and you're deciding to re-challenge it, don't expect colitis to come back as the only adverse event. You can have pneumonitis come back, you can have skin toxicity come back. Another thing that's also could help you decide if you want to re-challenge your patient if your immune-related adverse event required hospitalization. So if you had to hospitalize the patient for your immune-related adverse event, it is more likely to recur. and also the early onset immune-related adverse events. So if it started within the first 3 months, it is also more likely to recur. So on treatment management, this is a little bit of a gray zone. We really don't have any data on how often should we check the TFTs, CBC, and LFTs, what exactly needs to be checked. There is some effort from Brazilian colleagues actually have a guidelines, which is in language I don't speak at, so I couldn't really translate it. But basically, what I would recommend is thyroid function tests, CBC, LFTs, every 6 to 12 weeks. And then other one, ACTG or cortisol, kind of a symptom-based on fatigue or other things. And then frequency of the follow-up depends on how severe your adverse event is. Key to safe administration of immunotherapy, education, education, education. You have to educate your nurses, you have to educate your patients, and you have to educate your emergency room physicians and hospitalists. In our hospital, we actually have a yellow banner on the top of patient's electronic medical record, so everybody sees that the patient is receiving immunotherapy. So kind of other couple of tips for you. So this is a patient's monitoring tool that you can actually get from NCCN website. NCCN is actually coming up with immunotherapy management guidelines. The last I heard, it's going to be available beginning of next year, where you're actually going to have like your typical NCCN guidelines telling you what to do with immunotherapy-related adverse events. This is my favorite paper by Champat going through management of immune-related adverse events. Many pharmaceutical companies on their websites also have guidelines on how to manage immune-related adverse events. And this is my final slide. So what I showed you today is immunotherapy compounds have unique toxicity profile. We have to be proactive and knowledgeable and have to anticipate immune-related adverse event. Education is key, and there are many resources that can help you and your patients to withhold immunotherapy adverse events.